So hi all, this is Ashley M. Policy, Virtual Education Coordinator from Pallium, India. So I hope I am audible. Can I get a response?
Yeah, you're audible, ma'am.
Yes, you're audible.
Hello?
Yes, we
Yes,
can
I am
hear you.
audible. Yes, we
Yes, we can hear you. Ashley, we can hear you. Can you hear us?
Hello?
Hello, Ashley, can you hear you? We can
Yes,
hear
yes.
you, dear.
Okay.
Yes, ma'am, we can hear you.
So before starting of the session, we will have just a small introduction about Pallium India assets. So Pallium India is a national registered charitable trust which was formed in the year 2003. And it is an NGO out of Trivandrum, that is from Kerala, within the objective of alleviating serious health related sufferings of 7 to 10 million people in India. And we strive to demonstrate quality palliative care to educate professional and public and facilitate development of palliative care across services across India. And coming to Palliative India model, we look upon these three words, that is demonstrate, educate, and facilitate. So, of course, in the demonstration, we look into clinical link centers and through home care. And in the education, we have on-site as well as on-site training for doctors, nurses, healthcare professionals, etc. And also, facilitation team is the team who outreach joined several institutions or NGOs within this India as well as out of country also. And this is our training programs, that is mainly we are focusing on residential, online, and as well as on-site. As I told earlier, we are focusing on doctors, nurses, health aligned professionals, volunteers, which can be of general public, student volunteers, and palliative care beneficiaries as such. And coming to our programs, as I told earlier, we do have online and on-site programs, which is main the listed courses are like the courses which we are actually running on, and the foundation course in palliative medicine, which is of course for doctors, and we do have courses for nurses and also for the public healthcare professionals as such. So in details we can elaborate in the next session since the time is running out. So taking about the course of foundation course in palliative medicine, this is our course. So we have like a prescribed course that is 20 sessions we will be having. So starting from today, and it will end on 3rd June. And we will be having sessions on Monday, Wednesdays, and Fridays. So the timings are from 5 to 6:30. And we do have the ground rules of this certification is that we require 80% attendance, which we request everyone to turn on the cameras as such. So if you are facing any difficulties or if you are in another meetings, then okay. Otherwise, we do require everyone to turn on the cameras while we are having the session. So it will be nice. And also, we also look into assignments. We will be having 5 assignments, which we have to score at least 80% in all the assignments. And we do have pre-test, post-test, and end evaluation. So the pre-test is already circulated in the WhatsApp groups. So if anyone has not done it, please do as it early as possible. And all the learning materials will be uploaded in the IACO platform, through which you have joined. So all the session links, the faculty's PowerPoint presentation, and we do also have the recording of each sessions, which link we will be uploading in that particular IACO platform. And if you are facing any queries related to this, you can just message to us in the email address given below, that is tipsico@palliumindia.org, or in the WhatsApp group you can just message me. And this will be our course structure, which is like first 5 minutes will be the general introduction of the faculty and the participant, and next 60 minutes will be the presentation by the faculty, and we do have the case presentation, which we will be start from the next on the coming session. So today we will be having a small model of case presentation, which will be taken by Dr. Fahana. So that's about general introduction of this foundation course in palliative medicine. And we do have For this particular course, we do have facilitator Dr. Radha Venkateshan. So she will be here us from today till June 3rd. And also, of course, she will be there. And for taking this today's session, we have like Dr. Rajagopal MR. So over to saying just a few words about Dr. Radha Venkateshan. So she will be the facilitator. So like following the graduation, entered Tamil Nadu service as the medical officer in rural service in the year January 1991 and continued until joining the post graduation. And on completion of she joined in the government hospital as a tutor in anesthesia, and she tutored different aspects and also had done her postgraduate graduate diploma. And yeah, so that's a small intro of Dr. Radha Venkateshan. So I'll be limiting the sentence because we are running of time. And over to Dr. Radha Venkateshan for the faculty intro. Thank you.
Thank you very much, dear. Thank you very much. A hearty welcome to all of you for joining this course as such. Hope it is going to be beneficial in obtaining the knowledge, and also you will be having the opportunity to discuss a lot of cases and things like that through your case presentation and things, which will give you practical insight also. So without much ado, I will go on to introducing the faculty for today. A big thank you to Palliative also for giving me this opportunity. And today you've got the expert in that field to take all of you through this session. Dr. M.R. Rajagopal is the founder chairman of Palliative India, and he's also the director of the WHO Collaborating Teaching Tips Echo. And he is the person who has brought palliative care to India. And one of the important things in palliative care is the availability of morphine, which has been made available with the extreme effort and hard work of Dr. M.R. Rajagopal, making the availability of morphine easy through the implementation. And he has done that not in 1 or 2 states, he has done that in 19 states out of 29 states in India. And also, for all his hard work, he has been recognized in various ways. He has been given the Padma Shri, which is the highest award, 4th highest civilian award in India in 2018. And he has been recognized internationally also. He has obtained the international award from the Human Rights Watch in 2018 and 2014, sorry. And he has been, a movie was released by Moonshine in 2017. And also, the most important thing is his publication of his book, Walk with the Weary, in 2022, which is a worthwhile read, which he has compiled all his life experiences, which is very important to know how it is actually in reality. So that book was released in 2022. With that, I hand it over to Dr. M.R. Rajagopal. Sir, kindly take us through the session. Sir is muted.
That's fairly routine.
Thank you.
Thank you. I'm very glad to see that almost everybody that is visible to me has switched on the video. Thank you. It's very disheartening to talk to blank black screens. I have only one more request. Please give me a smile. Let us start with a smile. We are not even able to meet each other and shake hands. Yeah, thank you very much. Thank you.
Sir, good evening.
Hi, good evening. Who was that? Pushpaji, namaste. Listen.
Good evening, sir.
Hi, good evening. We have such a wide range of people in the audience. A very senior, almost ready to retire a doctor like Dr. Pushpa Kotur, and also some very young people. Great. Earlier, Radha said we will
Right.
try to impart knowledge. That is great. Let us realize that our virtual education has a major issue. It's easy to impart education, knowledge. It's easy to impart knowledge. That's not enough to practice medicine. As we all know, you also need the skills. What else do you need? And the heart. The head is all that we'll be attending to. You also need the heart, the attitude, and the skills necessary to give patient care. So please let us accept those realities and limitations. We'll try to do our best through the course. But please remember, for your education, preliminary education and palliative care to be complete, you will need a practical exposure. Dr. Sunil Kumar, our additional director, and Radha and all our team will be more than happy to receive you in Trivandrum for an observership. Please consider your training complete only when that's also done. With that introduction, was that a bit intimidating? I hope not. Let me tell you a story, a real life story, the story of one of the patients whom we treated before your time, Radha. Well before that, you wouldn't remember, you wouldn't know her. Prabha. Let me call her Prabha. That's not her full name, but I am taking the liberty to call her that. Prabha was 35. Living in the suburbs of our city, Trivandrum. She was a young mother of 2 children, both in primary school. Her husband was in the army. She, an ASHA worker, I forgot to specially welcome the people from outside India. I know that there are 4 participants who are from outside India. Hearty welcome to you from all of us. So those 4 may not know what an ASHA is. It is not the literal meaning of the word ASHA. ASHA is an accredited social health activist. Accredited social health activist. According to the current program, wherever, in most of India, it is applied. For every 2,000 to 3,000 population, there will be one ASHA. It's always a woman, as it stands now. She is from the neighborhood. ASHA is appointed only from within that locality. And she is responsible in a way for the health care of the people. Her most important activities are ensuring that women do get to hospitals for delivery, that other assistance is given. And the one ASHA told us about this lady, Prabha. Prabha had, at the age of 35, metastatic breast cancer. Like often happens, it was ignored when curable, and eventually she was at this stage. The story that was given to us was that her most predominant symptom was pain. She was in severe pain, and our team saw her. I don't know if, again, I hope everybody is familiar with the World Health Organization's 3-step analgesic ladder. This will be dealt with in detail in a subsequent session dedicated to pain. So I'm not going into the details. But if step 1, mainly of non-opioids like paracetamol, and weak opioids like tramadol, are if these are inadequate, we generally have the person on a strong opioid. In India and possibly in Bangladesh, the only opioids of this class available for this kind of use are morphine. In India, methadone and fentanyl. Fentanyl is very expensive. Prabha was put on morphine, and our team found that it relieved her pain very well. She responded well to morphine. But every time the team goes back, she would be in pain again. And they would find that she is not taking morphine regularly. So, for the third visit, I was asked to see her, and I went along to meet with Prabha. What I found was that Prabha was a bit defensive, almost angry. And when our team asked, why don't you take the morphine? She would say, I don't like the medicine. Why don't you like the medicine? It upsets the belly. She gets a bad belly when morphine is taken. So they would explain that, okay, we know that you had earlier severe belly ache with ibuprofen. This is not a medicine like that. It will not cause that kind of burning. And then she complained of constipation. But then when you took morphine with the laxative, you had good bowel movements. So every time they used to lecture her about the need to take morphine 4 hourly, which is the way we would like it to happen. But next visit, she is sullen and wouldn't respond properly, almost angry. What would you do? I hope you took those few moments to think. What I did, let me tell you. I went and sat beside her. I just told you an important lesson in palliative care. Very important lesson. Sit down. Doctors, tomorrow, one of you may be treating me. Like any of you, I have also only 10% chance of dying a sudden death. 90% possibility is that I will go through a prolonged illness. I hope one of you will be there to look after me. And when you come to me, if you are standing, looking down and talking to me and saying, how are you? I'll say, I'm okay, doctor. Sit down. If there's a chair anywhere in the neighborhood, pull it up. A stool. If nothing else, and if it is not one of those hospitals where the nursing supervisor will bark at you if you sit on the bed, sit on the bed. Please meet me at my eye level. Then you will be able to convey to me with your eyes and your face that you truly care for me. I may be in a strange place. I'm at that stage of my illness, I may be almost afraid of strangers. But with your smile, you are no longer a stranger, which is why we opened the session by me asking you to smile. It matters. Please convey to me that you care. So I sat down beside Prabha, lay a hand on her hand and said, Prabha, I know that you are in pain. You are suffering a lot. She didn't speak. I said, I am told that you don't take the tablets. How will you frame the next question, ladies and gentlemen? Hey, why don't you take the medicine? Is that acceptable? Priya is vigorously shaking her head. Not acceptable. Then you are like a schoolmaster about to punish the child. I told her, Prabha, if you are not taking the medicine at the proper time, there must be a good reason for that. Tell me what it is. Silence. What do you do when a patient in suffering is silent? Be silent. Usually the silence will last for less than a minute. If not, you may prompt. There must be a good reason, Prabha. I am your friend. I want to make you feel better. Tell me, what is it? She was still defensive. I don't like that medicine. Yes, Prabha. Tell me, why is it that you don't like it? It upsets my belly. I understand that, Prabha, but then I also know that with the tablets for bowels, you are able to tolerate it. Uh, I can't tell the time. I don't have a watch. What do you say? Would you get slightly irritated and annoyed? If you get annoyed, you have lost the game. Instead, say, instead I told Priya, sorry, Prabha, not Priya, sorry, Prabha. Prabha, there is a clock in the living room. Shall we bring it and hang it in front of you here? I don't like looking at the clock. Now, are you getting irritated? I don't like looking at the clock. I waited for a few seconds. I'm glad to see that the youngest participant with Dr. Ramesh is eagerly listening. I asked Prabha, why don't you like looking at the clock? She said, the clock tells me that time is passing. And she cried and said, I don't want to cry. I don't want to die. I have two small children. You see, very often we treat diseases, and you as palliative care people are able to look beyond the disease, to look at suffering. But we must also look beyond the suffering to the person. There's an Australian doctor by name Eric Castle, very famous person, who said, it is persons that suffer, not bodies. It is persons that suffer, not bodies. The morphine was being given to her body. We did not understand Prabha. So here was Prabha, who was being told by a clock that her time was passing and her time in this world was limited, that she may have to leave the children orphans, or the husband would remarry and then the children may be abused by the typical stepmother that is perpetrated by the serials on television. Prabha's problems were not only the physical symptoms, it was her grief, anticipatory grief, anticipation of death. Her relationship issues, he found that she was mortally scared of her husband. The worst time of her year, every year, was the 1 month when the man would be home on leave from the army. She also, now, later when she started talking to me, she said she loved her children very much, but she is unable to be smiling and pleasant to them. Gradually, the children seemed to be drifting away from her. She was being looked after by her sister-in-law. The children were looked after by her sister-in-law. And now she was worried that the children were getting more attached to the sister-in-law than to her. The relationship issues, the spiritual issues. What's the point of my being alive if even my children do not want to come to me? Nobody cares. I wish I were dead. Why did God do this to me? Is there a God? Please remember that, as Eric Castle said, it is persons that suffer, and suffering is in all these domains. Friends, this is what we are going to learn to manage. This is the one simple description. It's not an official definition. This phrase was brought in by a Lancet Commission report of 2017, the Lancet Commission report on access to pain relief and palliative care. And the report mentions this phrase, serious health-related suffering. It is now given the acronym SHS. This is what I hope we will all be able to do. Is that your duty as a doctor? Or is your duty to diagnose and treat diseases? Officially, as defined in India, this is your duty. Not only your duty, the duty of every healthcare provider, primarily to mitigate suffering. You have heard this. And the ICMR bioethics unit adds, there exists no exception to this rule. Dr. Raman, Dr. Jyoti, Dr. Badan, Dr. Fatima, everybody, there exists no exception to the rule that you have a duty to mitigate suffering. And how we are going to do about it is what we are going to talk about, because we have more around 7 to 10 million people in India, almost 1 crore of people in India who are in unrelieved, serious health-related suffering. Some degree of even basic pain relief reaches less than 4% of the needy. Dr. Anju, Dr. Naveen, Dr. Devashish, and everybody, please remember, I hope you will take it as your responsibility to think about this 1 crore of people, to talk, to be their voice, to advocate for them. In the 17th century, Osler said, the physician is the natural attorney of the poor. I hope now that you are learning palliative care, you will advocate for me as your patient. when my time comes. This is the official definition. As it is too long, WHO. It is 22 years old. WHO attempted once to change it, then did not arrive at consensus, just left it hanging in the air. But many of the phrases here are important. Most importantly, quality of life, quality of life, quality of life. Quality of life depends on all those four: physical, social, emotional, and spiritual factors. Through prevention and relief of suffering. We already said serious health-related suffering. Prevent it, treat it. For which we have to treat pain and other physical problems, pain, breathlessness, fungating wounds, any symptoms. And also emotional, psychological, social, and spiritual issues. Psychological, social, and spiritual issues. We will not go into all of this today. This is only by way of introduction. But just because we have mentioned spiritual, let us say it is not only about God or religion. It's about everything that's important to me beyond the material. My need to be loved. My need to love. My need to contribute to society, because if I am no use to anybody, I will be thinking, what's the point? I wish I were dead. You are feeling connected. All this is important, and I'm sure there will be a session later on spiritual support. Shall I pause there for a second and take any comments? We mentioned that palliative care is mitigation of serious health-related suffering, but also mentioned the official definition, which emphasizes quality of life, prevention and relief of suffering, and the physical, psychological, social, and spiritual domains. Any quick comment or question?
Good evening, Professor.
Good evening.
For such conversations that we should be able to have with the fellow human being who's present, we'll need to give very much amount of time. At times, time may be a limiting variable. Also, when someone is practicing so-called curative therapeutic oncology, at times these conversations may be difficult even for the healthcare provider himself, because he will not be used to these type of conversations. So how difficult is the learning curve from so-called therapeutic oncology to a so-called humanitarian palliative care?
I was trying to find out who was speaking. Can you identify yourself, please? Your name?
I am Archit Pandre.
Oh,
I
okay.
am from Postgraduate Institute of Child Health,
Okay.
Noida,
Okay.
Dr. Neeta's department.
Okay. Hi. Friends, very important question, isn't it? I know whether it's okay, he's in child health. I know that when there is an outbreak of one of those fevers, or when there is an outbreak of gastroenteritis, he may be seeing more than 100 patients a day. Where is the time to attend to social, emotional, spiritual issues? Let me tell you, doctor, I am there as your patient. I am anxious. I don't know what the hell, this could be COVID. And I will be isolated. That's one of the worst fears that I have. I'll be kept under isolation in an isolation room. And nowadays it's okay. I can be at home. Isolation at home is much better. I may be afraid of that. I may be worried, oh my God. I wanted to complete my will. I have not done that yet. And I may be worried about unfinished business. I may be worried about a lot of things. And you, doctor, you have only 1 minute or 2 minutes to give me. Doctor, during those 2 minutes, I hope you will still be able to sit down. It doesn't take time, doctor. You can do it along with your conversation. Look at me in the eye. I hope you won't look ferocious like some of the doctors are, especially when you have 3 or 4 degrees. You achieve a lot of muscle tone and your appearance becomes almost threatening. I hope you will be a human being. And if I look very anxious, even though you don't have the time to give me enough, I hope you will be able to touch me, if appropriate, and say, I see you are anxious. I am going to do my best for you. Enough, doctor. You have given me psycho-socio-spiritual support. You have acknowledged and validated my anxiety. You have conveyed to me that you care for me. And you have given me care. Somebody cares. And that is spiritual support for me. So, doctor, I quite see the problem. Ideally, I find it easy. We have medical social workers as many as doctors. If somebody is particularly anxious, I am sure when the rounds are over, somebody will go there and spend some time with them. But even if that's not possible in that environment, you still have the time to be human and to convey to me that you care for me. That's for the very busy person. But as you evolve your palliative care practice, I hope you will develop a team so that somebody will be with you. And even in the busy OP, maybe it is possible, not for everybody, to 1 or 2 people who look as if the weight of the whole world is on them, tell them, you look very anxious. If you would like to talk, get your lunch and come back and see me at 3 o'clock. That is, if you are able to do it. I don't want you to burn out. If possible, you might do that as an additional measure. But doctor, thank you for bringing up that important point. I'm sure there'll be more questions, and we'll have some time in the end for questions and answers. Dr. Akhila, how do I practice palliative care if institutes are not available or along with my regular profession? Doctor, till you are able to have a dedicated palliative care service, include palliative care as part of your work. Just as I said just now, convey to the person that you care. Treat the symptoms also, not only the disease. Face mask. Fatima, yes, we had a terrible time. And even now, it is maybe safer to use for you to use a face mask. There are many limitations. Just like the other doctor said, you have only 1 minute. What do you do? Similarly, try to smile with your eyes. And in addition, say the words, I am going to do the best for you. That's the best we can do. Okay, Priya says, during COVID days, we printed a smiling face and wore that mask. Okay. So friends, I am continuing with my introduction. Radha, I know how much of time we have taken. Hereafter, I think I'll be able to move forward faster. Please note that the WHO definition has a footnote saying that palliative care should be applicable early in the course of illness. in conjunction with other therapies that are intended to prolong life, such as chemotherapy, radiotherapy, antiretroviral treatment, anything, and investigations only if necessary. So start palliative care early. Doctor, you in your question, I'm sorry, I've already forgotten the name, the person who asked the question. You asked in oncology, particularly important, yes, oncology. The National Cancer Grid has already asked all member institutions, including most of yours, to integrate palliative care into oncology care. So that integration is to happen early. And we recommend that palliative care should start early. Old days, we would finish curative care and then only give palliative care. Today, according to the degree of suffering, both go hand in hand. Till a time comes when disease-specific treatment may be irrelevant, then palliative care alone may continue. And please remember, by the WHO definition, the palliative care is not only for the patient, but also for the family. Therefore, when the patient, even if the patient dies, the palliative care continues in the form of bereavement care. What you are able to do may be very limited, but within your capacity, you may not have the facility today, but I hope someday we'll remember that need. So this request for integration of palliative care into health systems in primary, secondary, and tertiary levels of care for the GP as well as for you, doctor, in the Institute of Child Health in tertiary center. Integrate it across the continuum of care from the beginning and the suffering to the end. Let me bring up a symptom as an example. Suppose your patient is coming to you in advanced cancer with severe breathlessness, breathing like that. You know it's advanced metastatic cancer. You know that the options for disease-specific treatment are exhausted. Patient already had some palliative radiotherapy. I could be there, doctor, tomorrow in that position. I have about 1 in 10 chance of, like everybody else, of dying with cancer. And if that happens to me, please, 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 for heaven's sake, do not imprison me in your intensive care unit. I was an intensivist. I know the value of intensive care. I know it can save lives. When life is salvageable, in advanced metastatic cancer, for heaven's sake, what's the point? What's important for me? Important for me is to hold the hand of a loved one, maybe my son, maybe my wife, because I am scared. How will you reassure me? Don't say everything is going to be okay. Everything is not going to be okay. I know that. Instead, say, I see you are suffering. Validate my suffering. We are going to try your best. If it is possible, say, one of us will stay here. Not necessarily you, doctor. One of us will stay here till you are a bit more comfortable. Oxygen may help, may not help. No point in adding the additional suffering of a mask if it doesn't help. Say, we'll try this for 10 minutes. If it helps you, we'll continue it. What may help is corticosteroids, which may take time. And later on, in the coming weeks, we will talk about morphine. In this situation, as treatment for breathlessness, I know, like you, I was also taught once that morphine is contraindicated in breathlessness. Today, it becomes a drug of choice in advanced breathlessness from advanced diseases. You see, this is how symptom control becomes different in the context of palliative care in advanced metastatic incurable cancer or even in advanced COPD. Advanced COPD, we can give low dose morphine, and it does help. It's not a theoretical possibility. I have seen this happen. So let me give you a poll. My colleagues are going to administer the poll. Will somebody tell them what to do, how to do the poll? Who is there? It is Ashley. Is it you?
Yes, sir. So we will be publishing a poll. So just you have to click on whether the statements are right or wrong. So I've released the poll now. So the first one. So I think it's visible to everyone, visible in the screen for the first question, that like the number of people going below poverty. Sorry. Sorry, my mistake. So
It's
this.
okay, Ashley. Ashley, leave it there. Leave it there. It's okay. No great harm done. We'll come back to the other poll. Only 31 respondents. We have 73 participants. Yes, yes. ये क्या हुआ? सो गई क्या? Actually, later on, will you be able to show this poll results again?
Yes, yes.
Okay. You can end the poll. It's okay. 43. So, Ashley, can you,
Yes,
ladies and gentlemen, this was my fault because I gave them the poll, the PowerPoint too late. But Ashley,
Yes, sir. Yeah.
hey, Ashley, it's okay. I
Yeah,
can do without the other poll. It's okay.
Yeah, just 1 second.
Don't worry too much about it. It's not all that important. Ah, there it is.
So the
This
next.
was what we were talking about. Good, 58. Some people have unfortunately dozed off, but thank you. Thank you. Friends, let me first talk to the one person who clicked the end of life. Of course not, doctor. When I am there in pain or breathlessness or in spiritual anguish, along with the treatment of disease, I want you, doctor. Or I want an oncologist or a general physician who understands palliative care. Please do not wait till I am dying to give me palliative care. At end of life, I want it, but it's not only at end of life. I would go with the first two answers, doctors. For the 7 people who clicked when the disease is incurable, no, 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 and no. That process may take a long time. I shouldn't suffer. Give me symptom control. Give me psychosocial support along with the process of arriving at a diagnosis. The first two are acceptable. The first one is what the WHO says. It has started the time of diagnosis. My personal suffering is to go into with the second one when pain or suffering starts. Okay, I hope that's clear. Thank you. Two
Sir,
people have raised their hands.
Dr. Premnath has raised his hand.
Dr.
So
Kotur, namaskar. You want to unmute and speak? Ask the question.
Sir, you can unmute and speak, Dr. Premnath. You can unmute yourself and speak. Yes,
Sir, am I audible?
Yes, doctor.
Yes.
Yeah.
Yes.
Sir, I just wanted to make a comment.
Yes.
When you were defining palliative care, 22 years back, WHO defined, and till today, the definition is rather unstable. What came to my mind is anything and everything under the sun which causes suffering comes under the purview of palliative care.
Dr. Kotur.
Your comments, please.
Dr.
Yes.
Kotur.
Sorry. Yeah.
My comment is by applauding. Precisely. Everything that is in an earlier slide I showed you, palliative care is mitigation of serious health-related suffering. Not necessarily serious illness, serious suffering. Serious health-related suffering. A bad cold on the day when a young man is going to appear for his civil service examinations can cause severe suffering. So thank you, Dr. Kotur, for highlighting that point. Everybody, please, I hope you took that message in. Palliative care is mitigation of all serious health-related suffering. Prevention and treatment of all serious health-related suffering. Radha, actually, somebody else had raised the hand in between. Was there? Or no?
Oh, only
Okay,
Dr.
okay.
Premnath we could see. If there was anybody else, please unmute and speak now.
Thank you, Dr. Kotur. 5:51. Radha is going to be very annoyed with me if I go on indefinitely. And I'm very scared of Radha. So let me move on. This is a breakup. I'm not going to talk to the details. Breakup from the Worldwide Palliative Care Atlas of diseases that cause SHS, serious health-related suffering. According to this, the Lancet Commission is slightly different, but mostly the same. Friends, only 28.2% of diseases. Oh, and add this 0.5% leukemias. Less than 29% of all suffering is caused by oncology conditions, cancer.
We can't see your.
Oh, I'm sorry. Thank you. Thank you for
No
mentioning that. And maybe I. Okay, Dr. Radha?
Now we can see, sir. Thank you.
So only 29%. This is HIV, dementia, other neurological disorders, cardiovascular and other diseases. Everything together warrants palliative care. Ashley, please note that my PowerPoint is to be shared with the whole team.
Yes,
so
sir,
that anybody can look at it and review. Also, mostly I have given the references, including the Lancet Commission report, so that you can look it up. This is what you already did. You majority just millions. Actually, it comes to crores. 5.5 crores are destroyed by catastrophic health expenditure every year. 5.5% crores doctors, our noble medical profession. We practice our noble medical profession and we destroy more than 4% of the population in 1 year. Hashmat, your pen with which you write a prescription has the power to starve children in the family today. Every single unnecessary medicine. When as a first choice you used to choose pregabalin or gabapentin instead of amitriptyline, you may be starving a child. Not a distant possibility. This is what I have seen day by day. And remember, the number of people killing themselves from catastrophic health expenditure. Sorry, from disease-related suffering are more than 29,000 every year. This is only the reported cases. Any number of times as many may be unreported. And please think, for every person who killed himself or herself, how many will be living after trying and failing? And how many will be living wishing they had the strength to do it? And unfortunately, the unreasonable practice of medicine causes more suffering in intensive care unit. This was written by Dr. Sankha Mitra, the founder of East India Palliative Care, an oncologist now practicing in Australia. I don't have to read it out. The worst misery happens to the rich. This will be dealt with in greater detail on when we talk about end-of-life care. But I just wanted to highlight that point. Earlier we talked about oncology. This is the guideline from National Cancer Grid. Please remember, more than around 300 cancer institutes in the country came together under the leadership of Dr. C.S. Pramesh, the surgeon director, onco-surgeon director of Tata Memorial Hospital. And the recommendation is, do not treat patients with advanced metastatic cancer in the intensive care unit unless there is an acutely reversible event. Intensive care units are not meant as death houses. They are meant for bringing people back to reasonable quality of life. And as I said, remember once more, palliative care is to be integrated into all healthcare. Not only for the dying, across the continuum of care, from the beginning of the suffering to the end. And if we have to do that, palliative care has to be integrated into all healthcare. Doctor, I'm sorry if I have forgotten the name. One of the doctors asked whether a pathologist or a non-clinical person can do it. If you can teach, and if you are practicing medicine other than in your regular work of non-clinical work, you could include it in your practice. And maybe you will find it worthwhile to do this. Dr. Vidya Vishwanath is anybody from Andhra? Oh, many people are here from Andhra Pradesh, largest contingent. Dr. Vidya Vishwanath is the head of palliative care in the Tata Cancer Institute in Visakhapatnam, Vaishag. She's a pathologist. She was a pathologist by training. Eventually, she left it and took this up. So whether it's part of your general practice, I'm glad you learned it, even if you are in a non-clinical side. So to complete, we specialist palliative care providers may be seeing only some. The bulk of palliative care delivery is by every doctor, every nurse, every social worker, every physiotherapist integrating palliative care into their work. Is that possible? And the community being there for support. Please remember, we will be talking more about this in the subsequent sessions. But this integration can be possible only by inclusion in national policy, but in your own hospital. That was another question that was asked in the chat. even as an individual. In your practice, you can integrate it. And at the national level, good things are happening. India now has a national program for palliative care. The National Health Policy of 2017 includes palliative care. The law governing opioids has been amended in 2014. In another session, that will be dealt with separately. And thankfully, see the bottom panel? Undergraduate MBBS and nursing curricula now have palliative care. It is spread out over various departments, starting with the foundation course with an elective in-house surgery. So, doctor, you asked whether a pathologist or an oncological person can contribute by studying palliative care and helping to teach it in your institution. You can help. I see that I have exceeded time, but with Radha's permission, let me just take 2 minutes. These 2 minutes, I'll shut up and keep quiet. Actually, Radha, let us all keep quiet. Let people reflect and contribute any important learning point that you learned today. Please try to avoid repetition, and I'll wait to read your chats. Thank you, everybody. I can see that Ashmat, Radha, Ashley, aren't you happy?
Very happy, sir.
Big thank you. See, the responses have already shown what they need to know. Salient points have come up. What is needed. So a big thank you. Nobody else could take this session as well as Dr. M.R. Rajagopal does. And as he has been mentioning, every aspect of it will be dealt with in great detail, along with case discussion and things. So, knowledge, skill, experience, all three are equally important, as was mentioned. And we will give you a taster of this, how important it is. So, eventually, all of you will want to have hands-on experience, which can be provided, and Pallium will always be willing to walk with you until you get established and things. And every element, communication, pain itself, you have so many sessions. and end of life care, then psychosocial element, then implementation. How actually you can do or set up a practice. Even for that, you will have a session and an entire session on morphine. And morphine's other uses will be dealt with as we go through. So everything is equally important and will be covered. And along with that, I will walk with you all and be willing to clarify queries and doubts. And we will discuss cases also as we go through. A big thank you once again, Dr. Rajagopal, for taking us through this session.
Thank you.
And Ashley, I think, shall we go ahead? If
Yeah.
there are no more queries, we'll go ahead with the case presentation, because that will be, again, a model for all of you today, so that very soon every one of you can come up with cases, because only with case discussion things will be complete. Every topic, see, you could bring up cases after the case presentation. I will take you through that. So just listen to this, so that this will be a sample for all of you to know how you can come up with cases, and then we can move forward with. I'll hand over it to Farhana. Nice to see you, Farhana. Go ahead with it.
Thank you so much, ma'am. Am I audible?
Yes, we
Yes.
can hear you.
So, yeah. Yes. Good evening, everyone. So I'm Dr. Hashmat Farhana from Palliative, and I'll be doing a model case presentation today. So here we have a 39-year-old male who was diagnosed with traumatic quadriparesis with stage 3 pressure sore on the sacral region and left gluteal region. Next slide, please. So the presenting complaints were he had a large ulcer over the sacral region and left gluteal region for about 3 weeks, and pain over the left hip and wound side for about 2 weeks. Next slide. So the history of presenting illness goes this way. He had a history of fall while carrying heavy weights, which was followed by neck pain and weakness of both lower limbs. He was taken to Medical College Hospital at Trivandrum and was diagnosed with traumatic quadriparesis in August 2023. He was admitted and got treated from there and was discharged after 1 month. After 6 months, he developed a bed sore over the sacral and left gluteal region, and he has a history of pain over the left hip and wound side for about 2 weeks. Talking about pain in detail, so he has a pain over the left hip region, which started 2 weeks ago. The provocation factor was minimal movement, and the palliating factor was rest, as well as it settled with analgesics. The quality of pain was continuous and aching. There was no radiation of pain. Next slide. And at the site of pressure sore, the onset of pain was about 2 weeks ago. The provocation factor was movement. The palliating factor was with analgesics. The quality of pain was continuous throbbing type. And due to this, sometimes they keep the wound open. There was no radiation. With the severity, it was moderate with a pain score of 4/10, and temporal factors were nil. The sleep was disturbed due to pain, and the oral intake was good. His bowel and bladder habits were normal. Next slide, please. And when we do the general examination, he was conscious and oriented. The temperature was normal, pulse 82 beats per minute, respiratory rate was 20 breaths per minute. The BP was 120/70, and the systems were normal. Next slide. On local examination, the sacral region had a pressure sore of size 7 to 6 centimeter, which was stage 3. Slough was present and foul smell was also there. On the left gluteal region, the size of the pressure sore was 6 into 8, and it was a stage 3 with slough and foul smell. Next slide. So the treatment and significant investigations, routine investigations done, hemoglobin 10 gram percent, the total count was 34,000. And the differential count was 80%, lymphocytes 18, eosinophils 2%, and platelet 1.6 lakhs. And the serum creatinine levels was 0.9, serum sodium 134 milligrams per dl, and potassium 4 milligrams per dl. The treatment given was TAP tramadol 50 milligrams thrice a day and SOS, TAP paracetamol 500 milligrams 6 hourly and SOS, TAP bisacodyl 5 milligrams 2 at night, 2 tablets at night, syrup lactulose 15 milligram at night as SOS, TAP metoclopramide 10 milligrams 1 as SOS, Airbed, advised to use an airbed, position change every second hourly, and wound dressing twice daily, cleaning and dressing the wound with Deprides ointment over the slough region. And for the foul smell, metronidazole irrigation was advised. The caregivers were asked to keep the wound closed, and white petroleum jelly was given for local application over the skin. Next slide. Moving on to the psychosocial aspects, he is a 39-year-old unmarried man living with his 65-year-old mother in a rented house. He has one sibling who is married and living separately and not caring and helping them. He was a manual laborer and was the primary breadwinner of his family. Now his mother has taken up work, a manual laborer work, and she is taking care of him. Now the main source of income is from the mother's daily wages, her pension, and some of his friends are also helping him. They have taken around 1.5 lakhs from a private finance bank for the treatment purpose. He was a devout Christian, now unable to go to church, and this makes him very sad. He says to his mother, like, I don't think I can walk, so please don't spend money over my treatment. Next slide. So the main concerns were pain, pressure sore, and the financial problems. And next slide, please. So the summary is a 39-year-old man with traumatic quadriparesis with a pressure sore, which is present over the sacral and left gluteal region, which is of stage 3, with pain over the left hip region and the ulcer site. Next slide. So the discussion points are, do we need to provide palliative care for this patient? What are the problems faced by this patient, and what all can be done for this patient and his mother, who is the primary caregiver? Thank you. Radha ma'am.
Yes, dear.
This was a model case presentation for you all to know, because in the upcoming sessions you will be presenting cases. So that's the reason why we thought we will present one model case scenario here. And over to you, Radha ma'am.
Yes. First thing, Dr. Emma Rajagopal, sir, it's anything you wanted to add on?
No, rather, that's fine. I mean, like I have spoken for a whole 1 hour. Enough is enough. I'm more than happy to leave it to you and Hash.
Yes. I'm happy to take it forward.
Okay.
Thank you very much. I will introduce
Bye-bye.
them to how to go forward with the case presentation and rest of the program, sir. I'll take them through.
Okay, thank you.
Thank you
Bye,
very
bye-bye.
much.
Bye. Good night, everybody.
पापा आपको क्या लगता है कि शिक्षा जगह
Ashley, can you hear me, dear?
Yes, I can.
You can't see me, isn't it? I don't know why
I can
my
see you.
camera.
No, ma'am. No,
It's
we can see
visible.
you.
Okay, if you can see, because I can't see myself. I don't know why. Never mind. That's not a.
We can see you, and your
Okay.
fan is beautiful, madam.
Okay.
The fan is
Thank you
such a
very much.
fabulous fan.
Okay,
Thank you.
okay. So main thing why we have had this case presentation is just to know that it's just as I said, it's a model. Okay, don't ever think that exactly what was all mentioned needs to be there. Okay, but as you would have all got the schedule for all this 20 sessions, no? Pick some case appropriate for the day. That is the important thing. And it could be, don't think that it has to be something, because if it comes from you in this format, and main thing what from the session today you would have understood, we have to deal with all aspects. Okay, so that is why we have, and the course has to be complete. You have to see, end of the day, all of you are going to see patients. You're already seeing patients. Okay, it is just enhancing your skills. That is what is needed there. So bring up cases and then appropriate to your field, your the topic of the day. And if everyone comes with cases, and we'll see if there are many cases, we'll pick which one is more appropriate. And at the same time, all your cases will be evaluated. So everyone has to present, best is to present something. And as we have more case discussions, you will see, for example, the problems and issues you will know only when you deal with the case. And no, not every case is the same. Every case is unique in itself. Take the case of Prabha, what was presented today. Why she did not take morphine? All of you, so many things went wrong, okay? So many times you will see through on. So I will not spoil the richness of the whole program, okay? Like for pain, everything, you will have many more components to it. Every topic, see, today was a test for everything: pain, communication, psychosocial issues, where to manage, when to go into ICU, when not to go into ICU. So that's what, not that we are, as Dr. MRR mentioned, if ICU is there, him, myself, and all, we're all anesthetists. We know the importance of ICU. We have done intensive care for 25 years. So no, we will do the best at all times. When ICU is needed, I will put 200% into ICU. When ICU will not be beneficial, I will do the same 200% to support and give the best care to the patient. Okay, so that is the way to look at it. So now, any queries? Anyone has any queries, either with the case presentation? Because if you have anything like that, please do ask. And you all can pick up, Ashley, they can pick up the cases. You can pick off the 20 sessions, whichever you would want to present, in which topic you feel that you have cases to present. You can do that. Get in touch with Ashley and the team, and start sending in your cases also appropriately. So if you can pick the topic, and then accordingly, all of you can choose that or not, do that also. All those communication will be sent, Ashley, for that?
Yes, it's already, the list is already circulated in the WhatsApp group. So
correct, exactly. So that is how it is done, so that you can pick. So you need not feel, oh, this is what I can do well. Pick that up now itself and do whatever, and then anything which, and then start preparing for it. See, keep doing everything along with it, so that you're studying cases, everything is done, and you need not put extra. You can do it comfortably in your routine. Anything, any specific queries anybody wants to ask? Like anything of like queries in today's session also, feel free to ask, or with the case presentation. Both of them, I am okay to answer whatever you need. Yes, Shanmuga Priya, you can unmute and speak.
Good evening, ma'am. So regarding the case presentation, I'm not associated with any palliative care or with the hospital as of now. So can I take up one of the cases? It might be a friend.
Dr. Sachin, please
There is
unmute yourself. Mute yourself.
Yes, you were about to. You can bring up some case. What you were telling? Try to say that again, please.
Associated personally, yes, yeah, I have.
Yes.
Yes.
You can.
Yes.
You can.
Okay.
So that can be done. Not that it should not be. You can do that, and please.
So for all case presentation is the 20th is the due date now. In the first message it was conveyed that way, even if the topic is on some other day. And
Ashley, can you answer that question, please?
you can book till the 20th. The
Okay,
last,
okay.
yeah. So booking
See,
the
that
slot
is
will
for-
be
Send
the
in the case
20th.
presentation, at least 24 hours before.
Yeah, at least 24 hours
okay.
before you have to check.
Thank
That's
you.
it.
Thank you.
See that 24 hours or couple of days also will be better, because see, it's all
Yes.
for everyone's best interest. Okay. So if someone doesn't have, or if that 24 hours, don't leave everything for the last 24 hours. That may not be good for all of you also.
Yeah, sure.
When you're going to present, if you're going to leave it for 24 hours, will you be happy to do it?
No, I just wanted
Okay.
to do the duty. Yeah.
No. I'm also, see, just
Yes.
for convenience and comfort of everyone also.
Definitely.
So the thing is that if you pick the same thing, what I was also telling is, if you pick the cases of your interest, you can do the best. So that is the important thing.
Ma'am, can I add something here?
Yes, please go ahead.
Yeah, so Dr. Shanmugapriya, the real reason why we want you to send it much earlier is because after you send the case presentations to us, we have the internal team of doctors who will go through your case. And then if there are any, if we have any comments on that, or even if in the discussion points, we would want to highlight on some other factor, but sometimes because the discussion points will be you people might have put 6 to 7 questions, we might need to make it much precise so that it fits into that half an hour of case discussion. So we will make sure that the important point comes there so that the discussion also goes really well. And also, if there are any errors with your presentation, then we will have time to actually vet your case and then send it back to you with the comments so that you can rectify it and send it back to us again. So the 24 hours, I think it is I think it would be a last moment. So if you can send it like 2 to 3 days
Definitely, I
prior, it will
understand.
be really
Yes.
helpful. I'm
Yes,
just
yes,
communicating it with all the participants. So if you have cases, there will be a template which will be shared by Ashley. So the template will be sent on your email. So you can make use of that template. Whatever that I have presented today is a template from our end. So you can put your information all over there and then send it back to us, just like how we do our case presentation right from our MBBS or BDS times. So just put on that and then make sure that you include more points on psychosocial aspect, because that is something which is very different with relevant to palliative care. So include points on those aspects and send it back to us, and we'll vet the case and get back to you as soon as possible. Thank you.
Thank you. Thank you so much.
See, exactly, appropriateness for the day. Thank you, dear. So that is why, because if the case is appropriate for the topic, and in that also, see, generally, if you take up any case, it can have all elements. We are telling total, no? Again, one thing I will tell you, you will always hear total care. That's what was mentioned today. It is just not one element, okay? When we are going to look at total care, we need to have total care, but also we have to give importance to that particular day's topic. Okay, so just fine tuning so that everything, see, in this whole 20 sessions, you are going to get a full information, but at the same time, you should get information on particular, for example, I'm telling, respiratory or gastrointestinal. You should know that also in depth, and the total element. So for those type of things, as they were trying to explain, when we go through the cases, we'll see what is not that, as I said, no, if 4 people said no, we are not discarding anyone. We will see what is most appropriate for that day. For that only, those type of going through the information and picking the one which is best for that day, for those things, it will be helpful if it is sent ahead. Okay, and as Shanmugapriya mentioned, you can, for example, some of you may not be already working in palliative care. So something, but Dr. Premnath also mentioned, so palliative care is there in every specialty. So that is also should have been revealed today, so which can help you to bring cases. Okay. Next thing is that if you're not working in palliative care or you can bring, see, everyone has someone with these type of issues in your own families also. So in those situations, you can not explain like as particular name and things, you can change information and then present too. So all these, we all have, the profession what we are doing has given us so much of insight. So you take something which is appropriate so that you will be able to present, and it will bring discussion to all. And it'll see, when discussion happens, many more elements are brought forth. And discussing in such platforms will give you such a wide experience. You'll be more confident and comfortable when you actually see patients, because what is the end benefit of the whole thing is that you should feel confident when you have a patient in front of you. Okay, that is the main aim. And then finding time and things, as the queries were asked, try to convey that you are there, and then you have to bring them again for another time. And then, so that will give you satisfaction, and patient will also feel, maybe as they say, no, everyone has 2 minutes. Okay, but in the 2 minutes, you can say, yes, there is an issue. I'm happy to sit and deal with you. See, for example, I'll just tell two simple example. I've been many times seeing outpatients. I'll be seeing 40 patients in one go. For example, when I used to work in Adyar Cancer Institute. So that's how it will be. But I will tell them, if you can wait for 5-10 minutes, once I finish some patients, or if they have something else, go back. If it's in the ward or something, I'll see the patients in the ward. Family, I'll tell them, come back at 2 o'clock. I will sit and discuss with the family for 10-15 minutes. So there is a way out for everything. Okay, just finding the time. And at the same time, as Dr. MRR mentioned, you need not get burnt out also. Just a little bit of planning and organizing, both for the patient and for yourself. Everything can be done. Okay, so anything else, any specific queries? Or else I will hand it over to the team, Palliative team, to take over. Ashley, you can.
Yeah, ma'am. So I hope no one has any queries. If you have any queries or anything, you can just mail to us, or just you can post in that WhatsApp group. And wishing you a good night, and thank you for joining the session. So we will be having the next session on Friday. So this is like 3 days in a week. So please do join as early as possible, like 5 minutes before that will be happy. So thank you, Radha ma'am, for joining the session, and thank you, Dr. Hashmat, for the case, for modern case presentation as well. And thank you all, and once again, see you all in the next session. Thank you.
Thank you, everyone. All the best to all of you.
Thank you.
Ashley.